Good morning, ladies and gentlemen. Am Dr. Kedrick Williams. I serve as one of the senior rural health project managers here at the Georgia Rural Health Innovation Center at Mercer School of Medicine, and also proudly serve as program director for the Maternal Health Observership Summer Program. And so at this time, I just want to quickly and briefly acknowledge the 2025 Maternal Health Observership Scholars. Scholars, if you all would stand. These are rising second-year Mercer School of Medicine students who are interested in becoming OB-GYNs. So as you are around them today, certainly encourage them as they're on their journey to become our next premier physicians of rural Georgia. Thank you so much. Before our speakers begin their presentations, I have been asked to share the following information with you. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Medical Educational Council of Pensacola, also known as MECOP, and the Mercer University School of Medicine. MECOP is accredited by the ACCME to provide continuing medical education for physicians. MECOP designates this live activity for a maximum of 5 AMA PRA Category 1 credits. In accordance with the policies of the ACCME, MECOP has collected disclosures from the speakers and planners involved in this activity. None of the planners or reviewers associated with this activity has relevant relationships with ineligible companies to disclose. None of the speakers have any relevant relationships with ineligible companies. Now coming to the podium is Ms. Elizabeth Gross to introduce our first speaker.
All right, good morning. I'll be introducing our next speaker, Dr. Keisha Reddick. Dr. Keisha Reddick is the Vice President and current President-elect of the medical staff at Memorial Health University Medical Center in Savannah, Georgia. She previously served as both the chair of the hospital department of OB-GYN and as the medical director of the labor and delivery unit at Memorial Hospital during the height of the COVID-19 pandemic. She's an associate professor of obstetrics and gynecology here at Mercer University School of Medicine, and she spent 5 years serving as faculty advisor for the OB-GYN interest group. She received her bachelor's degree from Spelman College and her medical degree from Morehouse School of Medicine. She completed her OB-GYN residency and a fellowship in maternal fetal medicine at Duke University Medical Center. For the past 10 years, she and 3 partners have maintained a busy perinatology outpatient and inpatient practice, serving as the only high-risk obstetricians for one of the 6 perinatal regions and referral centers in the state of Georgia. Dr. Reddick has received numerous awards, including the Press Ganey Patient Satisfaction Award for Most Positive Mentions for a Provider, the Memorial Health OB-GYN Residency Program's Teacher of the Year Award in 2021, the Mercer University School of Medicine OB-GYN Department's Teacher of the Year Award in 2022, the Excellence in Medical Care Award from the 100 Black Men of Savannah in 2023, and the Morehouse School of Medicine's Distinguished Alumnus of the Year Award in 2023. She was inducted into the Alpha Omega Alpha Medical Honor Society in 2022. She is known for her work in addressing health disparities and is a frequently invited guest speaker at medical conferences. Her interest in reducing maternal mortality led her to establish a nonprofit organization, The Mother's Closet, which provides resources and wellness activities for patients experiencing high-risk pregnancies during their antenatal, intrapartum, and postpartum periods. Through all of this, Dr. Reddick is a devoted Peloton enthusiast who participates in 5K, 10K, and half marathon races, while also spending time with her husband, Dr. Bonzo Reddick, and their 3 children, Gabrielle, Gavin, and Juliana. Please help me in welcoming Dr. Reddick.
All right, good morning, everyone. Whenever I hear that bio, I think I'm just a girl from Columbus, Georgia. I am a Georgia girl through and through. I like my sodas to be Coca-Cola, and I like my peaches from the middle of Georgia. So this morning, let's see here. I was asked to give this talk a year ago, so I'm going to talk about Dr. Callis, everyone. So a year ago, Dr. Callens reached out to me, and she's done amazing work in rural areas. And she's like, I want you to come and do this talk. And I was like, oh, I don't know if I can do it, because I was going out of town the next day. And she like emailed me. I think she emailed Delta Airlines to see if I could get my flight delayed. She is nonstop, y'all. So anyway, she said, okay, I'll give you a pass, but you got to promise me this is the date. You're putting it on your calendar right now, and you're going to come this year. So anyways, I'm here today. And I appreciate them for asking me to speak, and also for rearranging the schedule, because as the bio said, I'm a mom, and so I've been pre-gaming this morning, trying to get kids different places, and I have to get out of here a little bit earlier today. So we're going to talk a little bit about maternal fetal pairs and high-risk pregnancies. And this is a pretty broad topic, so there's a few things that I'll kind of zoom in on, and a few things that we'll kind of back away from. And then I'll have some cases, because I like to tell stories about things. I have no disclosures. Nobody pays me to do anything but my actual job. Here's the objectives that I won't go over. So let's get started. So, when we think about pregnancy, I kind of think of it as a maternal fetal health interdependence. So what happens to one could potentially adversely affect the other. And I think we think of this often as whatever's going on with the mother, that it can impact the fetus. But there are some conditions where there could be a fetal anomaly that could impact maternal health. So basically, complications that can impact each other. And then really, how do we have a multidisciplinary approach to manage these high-risk patients? And that's what I've learned really in the last 10 years or so. Like, we really do need a lot of hands on deck. I always say it takes like a village to take care of a patient, because some of our high-risk patients have so many things going on that I can't solely manage all of them by myself. I need extensions. When we moved back to Georgia back in 2014, I gave a talk about maternal health and maternal morbidity and mortality, and I was pretty astonished. I was unfamiliar with the stats until I moved back, and I was like, how are we ranking so high on such a significant statistic? Like, what are we It's not even that many people that live in Georgia. What is happening here? Why is there such a disparity where Black women are 9 times more higher rate to die from a pregnancy complication or postpartum than white women? I really was having a hard time wrapping my head around it. But at the same time, I was also seeing that our patients were just so much sicker. I often say that with my partners. I'm like, 10 years ago, 15 years ago, we never saw this much DKA. We never saw all of these things, but we see that we have just a sicker population of patients, and how are we supposed to manage these people? So what is a maternal fetal pair? So the patient, or the mother, and the fetus are considered a single unit, if you will. And as I said earlier, the health outcomes of one will and can impact the other, and management decisions that you make impact both. And I think that's where sometimes the crossroads happens for a lot of us is, okay, well, we have this condition going on with this mom. How are we going to manage her, but also safely get her through a pregnancy without causing harm to the baby? So it requires a lot of integrated management throughout the entire pregnancy. So again, I'd like to highlight that I am not the captain of the ship of this management of care. There are multiple captains on the ship in terms of how we manage patients. And if we don't acknowledge all of those groups and we don't recognize that, then we're doing a big disservice to the patient. How do we define high risk? So, my practice is called high risk obstetrics. And so patients are often very nervous when they come, even just for an ultrasound. But sometimes patients will say, am I high risk? And I say, well, there's high risk, but then there's really high risk. So we have patients that obviously have maternal or fetal conditions that impact their pregnancy and impact their outcomes. Some of the most common things we think about are, chronic diseases of moms, high blood pressure, diabetes, lupus, if someone has renal disease. But we also are faced with patients who have fetal anomalies. A lot of patients don't think something's going to happen. It doesn't run in my family. I'm like, it doesn't until it does. We see a lot of patients with multiple gestations, especially now that we have a lot of patients that are having assisted reproductive technology. And then obviously there's just complications from prior pregnancies that can then impact this pregnancy. And then sociodemographic factors. We really cannot ignore what is happening in our patients' lives. We just cannot. And I tell our residents this all the time. And I tell patients, I'm like, you probably think I'm trying to get all in your business. Well, I am. Because everything that is going on outside of your life will impact what you do day to day. So for high-risk pregnancies, again, complications that can impact the mom or the fetus, it also requires specialized care and monitoring. So I found this slide, and I found this to be interesting, and it said that almost 60% of patients know or have experienced some sort of pregnancy complication. And a lot of times, that's how I'll approach patients. I'll say, well, have you ever heard of this, or have you ever known of someone here with this particular condition? And sometimes that's just breaking down the barriers right there. That allows the patient to say, oh, you know what, I remember my sister had this and she had this terrible outcome. And I'll say, okay, well, talk to me about it so that I can explain to you how we're trying to avoid that outcome for this pregnancy. Most patients may have experienced or know someone with preeclampsia or high blood pressure. That's almost the most common thing. And then followed by preterm birth. So a lot of people are familiar with that, but a lot of people aren't familiar with a lot of these other conditions that they are faced with or that we have to manage. So this first clinical case is a patient I actually took care of the last time I was on call. She's 29 years old, first baby. She got admitted from our office because she had severe preeclampsia. That was her diagnosis. She had these crazy high blood pressure. She got admitted. We were doing all the normal things, giving her medications to lower her blood pressure, giving her magnesium, giving her steroids. So I go in to see her the next morning, and off the rip, out the gate, she says, I'm not staying here. That was the first thing she said. And I said, okay. I sat down and I said, well, let's talk about this. What's going on with you? What's happening? And it gave me the opportunity to pause, take a breath, explain to her, this is what's going on with your body right now. It is out of your control, but let me explain to you why I am so worried about your health right now. And I said, so tell me, why is it that you feel like you cannot stay? She said, well, I got all these bills I have to pay. I have to get to my job. My job, they're going to fire me. They're going to replace me. I have to go, my landlord and I have had a dust up before, and she's going to pull all my stuff out. I have all my baby stuff. And I said, okay, look, I can do you solid. Let me write a letter. I will write a letter to both of these individuals. She said, no, I want you to call them. And I said, okay. And I said, well, I don't know if it's appropriate for me to call your boss, but you can call your boss and introduce me, and I'm happy to speak to them. So I spoke to her boss. I mean, this is all in the morning of me rounding. And so I spoke to her boss and said, hey, she's in the hospital. And I told the patient, I'm like, I'm not telling them your business. I'm going to tell them you're in the hospital, kidnapped by me, essentially. And I need you to stay here because I'm worried about your health and your baby. And I spoke to her landlord, who was a little taken aback, but also said that she would not put her stuff out. So I bring all this up, not to talk about what I did with this patient, but to just demonstrate this patient was about to walk out of the hospital, right? And so in a few minutes, I had to sit there and think, okay, if she tells me she's gonna leave, what am I gonna do? How am I gonna manage this? Do I need to offer her delivery? So all of these things that are going on in our patients' lives, that's not gonna help her cortisol level. That's not gonna help her blood pressure that's going up. So I think it just highlights that we have to acknowledge everything that's going on in your life besides the numbers that we're seeing right in front of us. Some of the more common high-risk conditions with a mom, preeclampsia, any type of hypertensive disorder of pregnancy, we see so much of it now, gestational diabetes, preterm labor, IUGR, all of these things that we often encounter, placental previa, and we see a lot of PASs, placenta accretive spectrum. So with patients having more cesarean deliveries, we're seeing patients with placenta accretas, which again, that's a much more complex pregnancy, a complex cesarean delivery. All of those things are very common. That is just literally the bread and butter of my practice. With our moms, obviously chronic hypertension, diabetes, we see a lot of patients with cardiac disease. Historically, I would see maybe 1 or 2 patients in all of residency. I can remember them by name that had a cardiomyopathy, but a lot of our patients who are of reproductive age may have had congenital heart disease that's been surgically repaired, or they may have had a cardiomyopathy and now they're pregnant again. So we see far more of that now. A lot of patients I see also with renal disease. We also have a lot of patients with obesity, okay? And we know that's part of the challenges within the South, but with that, those patients have higher risk for the complications above, high blood pressure, diabetes. But it also makes it hard for us for prenatal diagnosis because sometimes the ultrasounds are limited. Advanced maternal age, I feel like essentially all of our patients are AMA these days, but they are also very unique patients in how we manage them. In terms of high-risk fetal complications, congenital anomalies, Prenatal diagnosis has been pretty remarkable in us being able to get good images of babies and really be able to counsel patients about, hey, this is what we see. A lot of times patients come into my office with preconceived notions like, I don't want to do testing, I don't want to do an amnio, I'm going to love this baby. You know, they have all this list, and I say, well, let's look at it from a different angle. If your baby has this particular condition, it may not be wise for you to deliver it in this smaller hospital. My goal is to get you and your baby to the safest place for delivery. And when I say that, they're like, oh, well, you know what, now that you mention that, I kind of do want to get this information. Patients with growth restriction, it gives us the opportunity to do more monitoring. Babies with twins, there's different types of twins, and depending on the type of twins, it may be a higher risk compared to some that are not. Fetal infections, we see a little bit less of that, but again, I think I highlight that because it's something that people don't think about. And then obviously genetic disorders. In the last 10, 15 years, we've had expansion of non-invasive prenatal testing, which has been really clutch for patients who do not want to have an amniocentesis. But in a sense, it's also opened the door, Pandora's box in a sense, for us to find out about things that people would have never otherwise known about. So now that you know you have these risks, right? How do we identify the risk? Well, number one, I think people underestimate preconceptional counseling, okay? That gives me the opportunity to sit down with a patient and say, okay, you have diabetes and high blood pressure. I don't think getting pregnant is off the table, but I do think we have an opportunity for your health to get improved. Maybe we need to get your hemoglobin A1C better. Maybe we need your blood pressures to be lower. But sometimes preconceptional counseling is me saying to a patient in the last year, ma'am, you had a heart attack after your delivery. I do not think it's wise for you to have any more babies. So it's not always this, okay, yes, we can do all these things, but sometimes it gives us opportunity to explain to patients, this is a scary condition you have. I think you're putting your life at risk if you do this again. So we see preconception counseling in our practice for all of those reasons and more. Capturing patients for their first prenatal visit. This is the time where I say, this is time for me to get all in your business, okay? It's time for me to really dig deep into what's going on in your life, what your healthcare is like, so that we can now figure out pathways that we need to send you on to make sure we're taking care of you. Obtaining labs, ultrasound assessments. We do tons of ultrasounds in our practice so that we can monitor the baby. Sometimes monitoring the baby might be my first clue there's something going on with the mom. Sometimes we see someone that has a small baby and I'm like, where's this coming from? And mom may be developing preeclampsia. And then what screening tools are we using? We just talked about that we do routine ultrasounds. So in our practice, we do targeted ultrasounds, which are more detailed anatomy ultrasounds. We also do a lot of antenatal testing. So for patients who have some of those conditions, such as high blood pressure, diabetes, or even babies that are small or have complex and anatomical defects, we may do these monitoring so that we can see, is there any chance that we need to intervene? There is very often the case of patients in my office and they're coming for monitoring and I'm like, you know what, you gotta go to the hospital, it's time. And they are completely taken aback and I remind them and I say, hey, I gotta remind you and myself, we're doing this testing for a reason. We're doing this testing so that we can intervene when there is a problem. And then finally, genetic testing. So historically, there were different types of non-invasive or blood tests that we would use to do genetic testing, but in more recent years, we've been doing more cell-free fetal DNA or non-invasive prenatal testing. And it's been pretty remarkable, especially if you're looking at the more common chromosome abnormalities such as trisomy 21, trisomy 13, 18. But it also has allowed us to find out if moms have other mosaic issues themselves. And then obviously we still have amniocentesis and CVS. So this particular case is a patient of ours. She's 32 years old. She's had one baby before, okay? And so this is, again, where patients are like, I've had a baby before, that's been fine. Nothing's going on. She came for a routine anatomy ultrasound, and she got referred to us because she had a genetic carrier screening test that showed that she was a carrier for autosomal recessive polycystic kidney disease. Okay, so she had this carrier screen, and it flagged it. Whenever we have a carrier screen that comes back positive for a mom for any condition, we will say, okay, we need to check the dad, especially for autosomal recessive. The dad never got tested for whatever reason, okay? It just never did. So we decided to follow her back up at 31 weeks because I was like, well, you know what? If you have this carrier condition, let's make sure you come back and we can look at everything again. When she returned to our office, the baby's kidneys were obviously abnormal. They were polycystic kidney disease, and the baby had no fluid. And it turns out that the dad also got tested after this, and he was also a carrier. So again, I think this highlights for patients, yes, you can have a normal pregnancy, but maybe you are a carrier for a condition that you never knew about. Unfortunately, with this patient, she ended up delivering in Atlanta and her baby passed away because there was no way that they could ventilate this kid. But my point is that I tell patients all the time, there's really power in knowledge. Doesn't mean you're going to change your pathway, but it is helpful for us to know what's going on because maybe there's some testing we could have done ahead of time, or maybe we could have prepared a little bit differently, or we can't change that particular outcome, but it's helpful for us to know this information because every pregnancy literally is different. For maternal surveillance, routine prenatal care is paramount, getting patients in. In our practice, we try to be very flexible with our patients about the times and dates they need to come in. I think that is very important within practices. Routine blood pressure and glucose monitoring. We have the ability for patients to email us. I try to really utilize that as much as possible because people drive a long ways to see us in our office. And so if you're able to email me, hey, I'll take it that way. Hospital admissions for severe conditions. I usually try to create a roadmap for patients and say, especially if I see that things are kind of changing, I'll say, you know what, I want you to understand every visit, there's a possibility that you may need to go into the hospital. It's not me trying to be negative, but it's also me just really trying to prep a patient for what things may happen during their pregnancy so they're not fully surprised. And then obviously some home monitoring programs in our area. We've used Secure Care and we've used Optum to be able to go out to patients' homes and be able to get those in-between appointment blood sugar logs, those in-between appointment blood pressure monitoring. It's always just helpful to have another touch point. So this slide again highlights everything kind of that we do for monitoring for patients, including fetal echocardiograms. And then let's talk about a little bit those particular conditions. So management of hypertension. In the last couple of years, there's been a big change about how we manage hypertension. We used to tolerate hypertension in patients, like 150s over 90s. But there was a trial that came out that showed, hey, if you have improved blood pressure control, you have better outcomes, and it makes sense. So these are the blood pressure medications that we typically use in pregnancy, and then using low-dose aspirin. I feel like a lot of patients get really confused when we say, hey, you need to use aspirin. They're like, I thought you said we can't use these medicines. And so really counseling patients and educating them about why we need it. Close monitoring of blood pressures. I'm very clear about your blood pressures. They need to be less than 140 over 90, period, point blank. And then timing of delivery. So there's a nice ACOG practice bulletin that talks about this. But I want to highlight on this particular slide that while we do all this monitoring, the one thing I do send my patients home with is if you think something's wrong, you need to call me, okay? I know the numbers might line up and they might look perfect, but if you get home and tomorrow you're like, I don't feel right, it ain't for you to try to figure it out. It's for me to figure it out, so come on back in so we can assess you. In terms of our patients with diabetes, I feel like we don't have great programs, at least for our facility, for nutritional therapy. Most physicians don't do a good job with nutrition discussions in general. So in a perfect world, I would have a closet that has like empty boxes of cereal and all types of things that we eat so that I can show patients, hey, this is why we don't want you to eat that. I do try to talk to patients about nutrition, but I'm also very realistic. So this is where I'll ask patients, like, what is your day like? What does it start like? If you're starting off in the morning, 5 o'clock, you're trying to get the kids up, I can see how you end up stopping somewhere on the way to work to get something quick. So I think it's really, what I try to not do is shame our patients, okay, and make them feel bad about the choices they're making. It's not the opportunity for me to say, well, gosh, why would you go do this? It's really the opportunity for me to say, okay, well, let me help figure out how we can restructure your day. I know I told you I don't want you to drink juices, but you think the whole household can get on board with this? Or I may say to the partner or the support person, the next time you go to the grocery store, could you maybe buy something else? Because it's going to be really hard for her to not eat that when you guys are eating that. So really engaging the family members. Nowadays, there's very easy ways for glucose monitoring, specifically with continuous glucose monitors, which historically 10 years ago, 15 years ago, we could never get those. So for patients who have an aversion to sticking themselves, I will write whatever prior authorization you need me to write for me to be able to get something for you so we can at least monitor your blood sugars. Insulin therapy is number one. That's your gold standard. Sometimes patients, they are unable to get it, so we are going with metformin. And then finally, fetal growth monitoring and delivery planning. I think for diabetics in particular, I just cannot stress enough that, again, very good education with the patients. I try to explain to patients often, your body is not what it was a few months ago. You got pregnant lady body. And so the way you eat something now is not the way it was before, and these are the reasons why we need to adjust. Preterm labor, we don't have any great tocolytics, but we do what we can. I think the number one thing is for patients who are showing up, giving them steroids for fetal lung maturity. I think it was in 2018, the study came out about looking at magnesium for neuroprotection. That study basically showed there was a significant decrease in IVH and therefore cerebral palsy. And then transfer to a higher facility if needed. So our facility is in one of the perinatal networks. We take transports from all of Southeast Georgia. Everybody knows when I'm on call, and Lauren could probably attest to this. I love taking transports, y'all. I love taking care of patients from rural areas because I know that we are able to do all the things that we need to do for these patients. So I try to make sure the communication with our referring physicians is completely open, and so that they know they can call us at any time for really anything.
She even gives them calls.
I do. When I'm on call, I'm like, where's Vidalia? I need y'all to come to me. So a part of my practice, we've talked a little bit kind of high yield for some of the more common pregnancy outcomes dealing with maternal conditions, but shifting to fetal anomalies. So we do prenatal diagnosis for us to be able to look for birth defects or markers for chromosome abnormalities. And this involves a detailed ultrasound we typically do around 20 weeks. Sometimes we have patients that have intracranial or chest abnormalities that may warrant them to get a fetal MRI. Sometimes there may be a need for in utero procedures, such as if a baby has anemia. But I think ultimately what I want to highlight is that this gives us the opportunity to get patients in the places that they need to be for delivery. So if a baby has trisomy 21, a lot of times people will say, oh my gosh, this baby has Down syndrome. Oh, they see the individuals on TV and they think, oh, this is fine. But babies with Down syndrome can die after delivery. They can be really sick. And so I explained to them, listen, it would be great if you could deliver at home, but at your home hospital, but that's not ideal. So we need you to be here. And then the last thing is abortion care. So I didn't speak about that with maternal outcomes, but I think that's something that we have to kind of go back to. We have some patients that have such significant medical conditions, the mother does. I've had patients who had dialysis and in the hospital. We had one with such bad lupus, she had pulmonary hemorrhage. Or we have babies that have such severe anomalies that are not compatible with life, that is a part of care and some of the patients that we take care of. So, it's not to be specifically just for fetal anomalies, but just to highlight that is a part of the care of some of our patients. With our multiple gestations, typically we're doing serial ultrasounds to evaluate fetal growth. We're also doing cervical lengths on these patients, but it also depends on the type of twins. So whenever we see patients or whenever we're getting referrals, we always like to get them as early as possible so we can determine what kind of twins do you have. Because if you have identical twins, we need to see you more frequently. Sometimes those patients may need to have additional procedures done. Monitoring for preterm labor. I try to counsel patients about what this all looks like for the rest of their pregnancy, and nutrition and weight gain. So we actually give our patients a book about nutrition and weight gain in pregnancy for twins and higher order multiples. Again, I think that the surveillance of these patients is very important because not only is there the risk for preterm birth, preterm labor, but we know these patients are at risk for diabetes in pregnancy. They're at risk for hypertensive disorders in pregnancy. They're at risk for things that you don't commonly see. So how do we wrap all that together? How do we really, truly take care of them? You need a multidisciplinary team. You just do. That involves an OB, MFM sometimes, neonatology, anesthesia. Let's say you have a patient that has a cardiac disease, or maybe they have a bleeding disorder like von Willebrand's. Well, we need to have anesthesia on board so we can know if this person is able to get a spinal, get an epidural. Do they need to be put to sleep? Genetic counselors, so they're key with a lot of these patients when helping them navigate and get the correct tests that we need ordered either during the pregnancy or afterwards. Nutritionists, social worker. I wish we had a social worker in our office. Our nurses are pretty remarkable in my office, so they are basically social workers by proxy. And then nursing and case management. one of the great things about our hospital is that we now have a perinatal navigator. And what she serves, I tell them, I'm like, she's like the chef in the kitchen. I tell patients all the time. You have so many people involved in your care, and it's overwhelming. Imagine you have a couple of medical conditions, and then you crop up at my hospital, at my office, and I say, hey, this baby has hydrocephalus, or this baby has a heart defect that may need surgical intervention. It's incredibly overwhelming, even for the most organized person. So the perinatal navigator at our facility serves to be able to get all of the information to everyone. If a patient needs to go up to Atlanta for delivery, or if they need to deliver in Augusta, or if they need to meet our neonatology, or if they need to have a tour, it really helps to have a central person, and she follows them throughout the whole pregnancy. So with this team care approach, what we do is we actually have meetings about our patients. And I tell patients, I say, hey, we have a navigator, and I just want you to know we all have meetings about our more unique, complex patients. And we're going to discuss you because we want to make sure we're all on the same page. The last thing I need is for you to show up at the hospital and someone doesn't agree with the plan and we haven't communicated this information to you. So all that to say is that I really think people sometimes underestimate a team-based approach for patients. And when you do that, I think there's gaps that occur, and there's plenty of opportunities to fill in those gaps with all of these individuals. But occasionally we can get into some ethical issues and challenges. A lot of patients have limited resources. They can't make it to the appointment. Dr. Reddick, it's gas money that I gotta pay. I gotta get a babysitter. I can't take off that many days. How do you do informed decision-making or shared decision-making? Going back to that first case, the patient has severe preeclampsia. We can expectantly manage patients with severe preeclampsia, but the only person it benefits is the baby. It actually puts the mom at higher risk because we're just sitting there trying to just put Band-Aids all over them. So really, you have to engage the patient. It's even something simple, I don't want to say simple, but even with our diabetic patients, when they come in, I'll say, okay, I've looked at your blood sugars, and I think you're going to need medication. And this is what I would recommend. Okay, I think insulin would be your best choice, but I recognize that sometimes patients aren't ready to do insulin for whatever reason. So maybe let's talk about metformin. I'm going to tell you why I think it may not be the best choice. And so the patients will look at me and I'll say, listen, if I didn't think this was an option, I wouldn't even give it to you. But it gives the patient an opportunity to say, you know what? Now that you've explained it to me and you've given me some opportunity to make some decision making, I think I'll go with what you say is probably the best thing. And then how do we prioritize maternal and fetal priorities? And I've had family members have always asked me, like, how do you select? How do you choose? I'm like, if I don't choose the mom, nothing's happening. So there's really, but sometimes there are some conditions, like if a mom has cancer in pregnancy, we are choosing the mom, but we may have to do an alternative therapy because some of the treatments that we would give the mom otherwise might be teratogenic to the baby. So all that to say is it's never easy, and I always tell people, we don't always have the answer right then in front of you, but I think it's important to communicate with the patients, hey, these are the things we're considering. I kind of want to get your input. Like I'll ask them, I just want to get an idea of what you're thinking right now that I've given you all this information. And oftentimes they're aligned with whatever the recommendations are. We just talked about the maternal fetal interest in terms of ethical considerations, informed consent. You haven't given the patients all the information that they need and letting them help make those decisions. Resuscitation planning. So we have some patients that have babies with significant abnormalities, and it gives us the opportunity to talk to these patients and say, how can we best honor this baby? Okay, we know that this baby has this condition, and we want to be able to honor this baby and honor your desires. What does that look like for you? Okay, so you broke your water at 21 weeks. What do you want us to do? How do you want us to intervene? And how can we respect your decision and honor it? And finally, are there palliative care options? So again, the patients who have babies that have complexities that are not compatible with life outside of the womb, how can we be gentle and with compassion to take care of you? So along those same lines, we also have someone who works with our patients who are unfortunately facing a delivery where a baby is probably not going to go home with them. And again, I think this just, again, highlights all of the people that are involved, that need to be involved with the patient. It is not just the physician. It is not just the doctor. It's not just the midwife. It's everybody that has to be on the same page. With delivery planning, you have to really match the maternal and fetal risk level. So some things I'll say, you know what, let me talk to your doctor back home and let me make sure your doctor is okay with you delivering. Let them talk to the pediatricians and make sure, even though your baby is small, that they are okay with delivering this baby there. If not, if they say no, then hey, we can take you on. We'll take care of you. Again, having multiple multidisciplinary meetings, we have a patient that's going to have a procedure in a week, and we've had several meetings about this patient so that, again, we are making sure we're closing the gap on anything. Talking with our neonatal resuscitation team and see, hey, are y'all ready if this patient comes in? We have patients that have complexities that need to deliver elsewhere, and we say, okay, how are we going to be prepared in case this patient comes in? What things do we need to have lined up at the hospital? Again, it goes back to the team and communication, timing considerations, and then postpartum care and transition planning. With postpartum care, and I'll have a slide about it later on, I think it's key for us to remember the mother in this, the patient in all of this. I think oftentimes it's like so baby focused that we forget about all the needs of the mom. So I think it's also important for us to say, okay, you got this baby that's going to be in the NICU. What is your support going to be like while you have this baby in the NICU? Who's going to be here to help manage, take care of you if you have a C-section and you're trying to get back and forth? And I think it's very important to have those discussions ahead of time. And also the mode of delivery, which again, to some patients may already have their mind made up. This is what I want. And I'll say, well, okay, let's talk about how we can achieve that. In terms of postpartum care, obviously we do a lot of maternal monitoring. In a perfect world, I would have a newborn nursery so my mamas could rest before they go home, but we don't have that anymore. Mental health screening, so we do this in our hospital, and we also do it when patients come back. We don't really do the 6-week postpartum. That's a long time for somebody to be home with a newborn baby, even if they had an uncomplicated pregnancy. That's just too long. I mean, you really need to be in contact, because what I find is, you get home, you have this baby, you're exhausted, you're tired, any little symptoms you may start to have, I don't want to say you're ignoring it, but you're so hyper-focused on this baby that's hard to pay attention to what's going on in your body. Contraceptive counseling. I talk to patients all the time. At postpartum rounds, I'll say, okay, when am I going to see you again? Or am I going to see you again? What's your plans? And, that gives me the opportunity to gently kind of go in and say, well, if you're planning more babies, I think we need to wait this amount of time, and this is why, and these are the things we want to talk about. This is not to be confused with coercion of patients, like saying you need to do Depo before you leave this hospital, but it really is opening up, like, I kind of want to know what your life looks like. What does your fertility planning looks like? You think you're going to have some more children? Like, I had a patient recently who had her 6th C-section, and I walked in and I said, I know we talked about this before, but I kind of need to know what is your game plan, because I want to explain to you what was going on in your C-section, what my concerns are if you try to do it again. And then just arranging follow-up appointments. We fortunately have someone in our hospital who rounds with me, a nurse who is excellent, and she helps make these appointments, because I find that once people are gone, they are gone, and it's hard to capture people back again. All right, so here's another case study, somebody who has diabetes and growth restriction, which is an awful combination, by the way. Those patients will sometimes come to us for referral. We'll talk about antenatal monitoring, and typically, sometimes these patients may need to get delivered a little bit earlier. Part of that asterisk is because there could be variation in timing of delivery, but I think it's important to communicate to the patient, you know what, you got a small baby and with diabetes. That is never a winning combination. And so as a result, we are trying to mitigate your risk from having a stillbirth, so we think you need to be delivered a little bit earlier. What is that going to look like? That might not mean that your baby stays in the room with you. That might mean your baby has to go to the NICU. That might mean you go home and your baby is still in the NICU. It's better to have these conversations up front than for people to be fully surprised when they get to the hospital and things have changed. Along the same lines, a patient with preterm twins, they show up with a short cervix at 24 weeks, and then maybe they have some cramping. These are patients who probably need to come to our facility. They need to go to a tertiary care facility so that they can get the appropriate treatment and management. So shifting to Georgia, because as I said earlier, I'm a Georgia girl, we have historically done very poorly with maternal mortality outcomes. We have obvious disparities with race and the region and access to care, but we've had some response initiatives that I think we need to expand on in the state. So along the lines of this entire symposium, what are some of our barriers? Well, number one, we have a lot of rural hospitals that are closing and we have provider shortages. There's issues with Medicaid expansion, and then how are we getting patients to their appointments, and is there opportunity for telehealth challenges? Every time I go to Columbus to go see my mom and I drive past that exit for Vidalia, I think, man, that is so far from my patients that have to come down here. Like every time it like resonates for me just how far it is. I mean, I know it's far, but when you drive it, it is far. I mean, it's far. So how do we define maternity care deserts? Okay, so if you look there, the definition of a desert is a hospital that does not have any obstetric care, they don't have any obstetric providers, and the proportion of women without health insurance is 18 to 64. And then you have low access, which are some of your at-risk hospitals, all the way to full access, which would be a facility like mine. In the state of Georgia, we have approximately 56 counties that are designated as a maternity care desert. 56 counties. These deserts impact about 104,000 reproductive age women. That's almost 6% of women in the state of Georgia. And an additional 8% of them live more than 50 miles from a critical care obstetric service. Can you imagine if you start having a seizure at home? Someone's then trying to get you the closest hospital. I mean, in the time and the delay it takes to get there, and then for them to try to stabilize them and then get them to me, and that's why we have higher morbidity and mortality rates here. I mean, it's really astonishing that we have areas where people are driving 50 miles just to see an OB provider. If you're looking at, these are slides from, these are images from the March of Dimes, but if you're looking at the distance to maternity care in a rural area, they're driving about 33 miles. That's a lot of gas too. I mean, think about the money that's being spent to get to an appointment. In an urban area, it's about 12 miles. If distance to care for maternity care access, if you're in a desert, 33 miles. Limited access, almost 20. And then full access is about 11 miles. So in Georgia, there is about a 4% increase in births in birthing hospitals. And out of that, about 5% of these babies are being born in areas that there is a maternity care desert, which means there's about 6,500 babies being born that have to be driven a distance just to get to a facility where they have obstetric services. So again, women travel about 13 and a half miles or 20 minutes to the nearest birthing center in the state of Georgia. The highest travel distance is 63 miles or 75 minutes. About 16% of them have no birthing hospital in 30 minutes. There is so much that can happen in 30 minutes. If I have a patient with a vasa previa and it ruptures, 10 minutes, that baby's bled out. Like, it is so many things that can happen in such a short period of time. In rural Georgia, 61% live over 30 minutes to a birthing hospital compared to 13%. I mean, we gotta fix this, right? So I want to highlight Wayne Memorial. So Wayne Memorial Hospital is within our perinatal region, and they closed back in February, and they've had Dr. Major, who's awesome, and she's been there forever. I remember she called me and said, I don't know if we're going to be able to stay open. And I said, what? What do you mean? Because they do about 50 deliveries a month. That's a good amount of deliveries. But they were having difficulty hiring providers to service the hospital. So in February, that hospital closed. And what happens? The patients still show up, y'all. They still go to Wayne Memorial, and then they have to transport them elsewhere. And we get some of them because they're triage visits because there's not an obstetric provider, or some of them that have a delay in a management because there's no one there to take care of them. So I highlight this because, we've known it's been going on, but then when it starts to happen, you're like, hey, I just got a transport from Wayne. I mean, I probably, on average, when I'm on call, probably get at least one phone call, and I take call 1 week out of the month from Wayne Memorial for a patient that they cannot keep there. So what are the implications? Well, you got to travel further. So if you're traveling further, then you're going to have a delay in care. You're going to have a delay in treatment. That's going to just increase your risk. That's just the bottom line. And we got to have a way to fix it. And then obviously there's a race component to it where Black women face a higher maternal mortality rate in this entire scenario of things that's happening. So what are some proposed interventions? Well, number one, telehealth expansion. I think COVID, with everything that it brought us negatively, at least opened the door for telemedicine. That has been a huge, I mean, prior to that, people were not getting reimbursed, so people wouldn't want to do telehealth. But now that there's opportunities for physicians to be reimbursed and you to have the resources, now we can, and have it all wrapped up with HIPAA, we can offer services to patients. So we actually have some additional offices because it's only, well, it's 5 of us now, but because we're covering our office and the hospital and our own clinic patients, we actually have a facility in St. Mary's. We also have a facility in Vidalia. We also have a facility in Dublin. So it's been great for us to do this outreach, and it helps the patient because they don't have to drive all the way to Savannah. And it also, because we can't always go to these other facilities. Increase in provider and recruitment. I think that was one of the issues with Wayne Memorial, is that they were not compensating people as they felt like they should have. And so as a result, they did not get doctors to stay in that area. Policy changes. I think one of the places that has done very well with outcomes is California. And so looking at policy changes within the state of things that we can improve on, giving support for these satellite offices that we can have nurses. And then Georgia Tech is also doing some modeling that looks at adding, they're basically saying if we added 16 new obstetric facilities that are strategically located, that we could cut that obstetric desert in half. Like 56 counties, and you're thinking you're going to half of that? That would be, pretty remarkable for our patients in the state. In the state of Georgia, there's different levels of care, basic care all the way up to our regional centers. And again, I serve the Southeast region. Coordination of care and referral workflows. So again, identifying risk very early, getting your NEOs and your OBs to be on the same page. But we also have the opportunity to do home visits with patients and learning which patients that need to be referred. So I know in our area, the Department of Health is being able, they have a program where they now go out to patients if they agree to do it for home blood pressure monitoring, urine dips. And that's been helpful for patients if they are agreeable to it. But I think that's helpful because you have a touch point. I'm going to skip over that slide. So what are some diagnostic and surveillance strategies? We've kind of talked about this before, but also I want to highlight again, home blood pressure monitoring and glucose monitoring, and having someone to be able to go out and assess these patients. Postpartum care in Georgia, follow up with hypertensive disorders. I believe there was a program that was started in Liberty where they had a text messaging program for blood pressures. If nothing else, it gives the patient a reminder, like, let me check in on my body. Hey, you need to check your blood pressure. Now let your doctor know what's going on. Figure out what the barriers are to postpartum care. A lot of our patients are running around with the kids that they have, or they're running around with this new baby, and it's hard for them to get to the appointments. So I encourage flexibility within the practice. And is there any state initiatives for us to expand postpartum Medicaid coverage? Here's just a list of some of the community and state resources that we have that most people are probably very familiar with. Some policy and public health implications. So one of the things that the state has done is that we do have obstetric bundles. That's a way of streamlining care. So, before it would be like, okay, I have a patient with a postpartum hemorrhage. Okay, what do we do? I guess we're going to give her Metrogen. But now there's a nice little bundle where it's like, okay, this is the flow sheet. This is what you're going to do. This is the next step in this. Same thing with hypertensive protocols that we utilize in our facility. And that's our outreach nurses have been teaching to our outlying communities. The role of Medicaid policy and telehealth expansion. Again, I think that it is remarkable that I'm able to talk to a patient about her diabetes by phone, and then she can just message me through my chart and let me know if there's any changes. And are there areas of improvement? And I would say absolutely, because we have not really decreased our outcomes as well as we should. And as I say, we have so many obstetric deaths, but there's absolutely ways for us to improve. And hopefully the people in this room will have some good ideas as well. This is another case example of a patient with diabetes and twins. I think one of the things that is helpful with MFM referrals is not just us managing your diabetes, but us counseling you about, hey, have you ever had DKA before? No. Well, let me tell you what this is. And this is how it may present in pregnancy, and how we can make sure we have babies in the right place for delivery. All right. In terms of statewide support, again, we have the PHP program, we have the ECHO program that I think some people in this room are helping to champion, and then looking at our MMRC data and really being intentional about, okay, what are the patients, these women that are dying in the state, what are they dying from? What are the things that we can improve in terms of decreasing those outcomes? This slide really just looks at maternal vulnerability to access to reproductive treatments, so such as contraception. Some of the hospitals in the state of Georgia are able to do immediate postpartum contraception, specifically like IUDs and the implantable device. Sometimes it's a little tricky with billing, so we've not been able to do it at our hospital long term, but I think that that is something that is helpful. I'm gonna skip over this one. All right. So I'm gonna conclude this because I think I might be going over my time frame for this talk. So in conclusion, I think number one is figuring out the risk identification for our patients. And how do you do that? You communicate. You give the patient the floor. You give them the opportunity to tell their story to you, whatever that is. Figuring out when a referral is necessary, having a multidisciplinary coordinated care, having multiple people on the team involved in the care of this patient, integrated maternal fetal care outcomes, improves outcomes, so having your MFM doctor involved, and tailored management with delivery planning. So, you know, what works for one patient may not work for somebody else. It really is individualized care. And then finally, leveraging Georgia's programs that we have listed here and participating in the MRC system improvements, which I think we have a long ways to go. And I'll just close out by saying, you know, as a former high-risk patient myself, I actually, with my last baby, got very sick, and I had severe preeclampsia with HELLP syndrome. And I was literally the patient that I care for, and I actually delivered my last baby at 30 weeks, and she was IUGR, she was 2 pounds. So I always, you know, I don't always share that with my patients, but sometimes when I see that, like, I'm like, I understand what you're going through. Like, I literally do understand what you're going through. But having experienced that and experienced having a baby in the NICU and the complexities of having other children, you know, I already knew that it was hard, but it really opened my eyes to like, wow, these people really, really have it hard, you know, and I actually have support, you know, to help me out. But that's why this is even more near and dear to me. And I'll tell people all the time, like, I truly do love what I do. I really do. I enjoy what I do. I get invigorated by what I do. Is it hard? Yes. Sometimes I feel like I'm fighting for my life, but I really do love what I do. And I feel very blessed to be able to serve my state, not just my community of Columbus, but I feel like coming to Georgia and being able to serve the community that raised me. So here are my resources, and I want to say thank you. Am I supposed to open up for questions, by the way? Okay, do I have any questions for anything? Does anyone have any questions?
I have one thing.
Oh.
Like, what county are you?
Chatham.
You're in Chatham.
I'm in Chatham County.
Okay, so you were talking about the automatic like contraception after birth and inserting like after she pushes out the placenta and all, y'all put that within.
Yeah, so there's an opportunity. You can do immediate postpartum LARCs, which are long-acting reversible contraception. So the two are the implantable device, which goes in your arm, so it's Nexplanon, and then the IUD. So there's lots of studies where they can do this. Now, there's a higher expulsion rate, but you can actually have this placed within 10 minutes after you deliver your placenta. So the benefit is that you're capturing the patient right then, right? And they don't have to come back, because a lot of times patients have to come for a consult visit, because billing for contraception devices outpatient is kind of complex and how they get billed. So a lot of times patients have to come for an initial appointment, then they have to order a device, and then they got to come back. So what happens in that time frame? Somebody gets pregnant. But yes, you can actually have that done. Yes.
Question. So, for the Georgia Tech study that said, you could reduce the desert if 16 knew, did they specify like what level would, reduce the desert?
No, I think they just were looking at like if you had them strategically located, but not necessarily, like, I don't know if they said like to how much, but I think it's more of like if we just have more facilities. So I think basically it's highlighting like if you have these rural areas, maybe we should have smaller clinics within a certain cluster of counties that is easier for patients to get to. And if you do that, rather than saying, okay, we're gonna just put one right here, that would be a much more strategic and better way to approach the maternity desert issue. Oh, yes.
Yes, ma'am, how you doing?
I'm good.
Foremost. Now help me, help me, y'all, let me understand, because this is like my second time coming to one of these events. So for the multidisciplinary care team,
Yes.
is the father involved in any of this? Because I know I hear the mother.
Yes. So and when I think of the team, I think of the healthcare team. I'm not necessarily excluding the father. So for us, when we're talking about the patient, I'm talking about everybody. I am talking about the patient, but it includes the support people as well. Whoever that support individual is. For example, if I go into a room and I'm going to have a very unique conversation with a patient, and we're going to make some decisions about timing of delivery or something. If there's people in the room, I engage all of those people in the room. Like, do you have questions about what I just said? Is there any concerns that you have about anything that I've just talked to your family member about? But the team itself is specifically the individuals that are providing the care to the patient.
Okay, I just wanted a little bit more clarity. And well, with this pertaining to the father, when you say postpartum care, and they were just like, who is that? Is they still considered part of the team because, after postpartum, and they're at home, like you said, 6 weeks?
Yeah, so, obviously, when we think about postpartum care, I think about everything that the patient would need. But oftentimes, and in our country, the mom is by themselves. Not because there isn't a present father, but because the father's back at work, or they're staggering their prenatal care. So again, I think it depends on how people approach our patients. Like, I'll ask in the room, who will be able to bring you? If you got a baby in the NICU, how are you getting back and forth to the NICU? Are you gonna be able to get in the Ronald McDonald House? Are you able to drive her back and forth? Like, I'm one of the people that will look at the other people in the room and ask you, how are you gonna support this patient?
Thank you so much.
I think there was one back here.
Focusing on patients with prior chronic disorders, when would you like them to get to the appropriate doctors to stabilize their disorders so the pregnancy will be easier and not high risk?
Can you repeat that question one more time?
Yeah, people who have prior chronic disorders, how early before planning pregnancy you would like them to go to their doctors? Not necessarily OB-GYN.
Oh, like their primary care?
Yes.
I would say 3 months, 3 months, because specifically with diabetics, if they have improved glycemic control for 3 months, they have improved outcomes, namely like less fetal anomalies. So I would say at least 3 months. If I see someone they're doing preconception counseling, I would say you need to have 3 months of better, improved blood pressures and glycemic control if they had like diabetes or high blood pressure.
Thank you.
I think you're next.
Oh, I just wanted to ask, I know you touched on it briefly, but I am a perinatal psychiatrist, so just wanted to touch on like what kind of resources do you provide for these moms that have,
Yeah, so that has probably been the weakest link.
because I
In our
started a
care.
program with my healthcare
Yeah.
system, so.
It's probably been the weakest link, and I say that because, number one, we just have fewer providers. We have a lot of patients that have publicly assisted insurance, so we have very few people we can get them in. And then there's the stigma of going to talk to someone. I think when we have patients that encounter, neonatal fetal death, we have bereavement, and so I think that that's a little bit different. But for the patients, like I had a patient who, she lost her son tragically due to gun violence, and that happened before she got pregnant. And it was everything I could do to try to get her in with someone. And sometimes patients will reply and say, well, I have my church family members, I have my friends, and I'm like, I'm glad they're there for you, but it's sometimes hard for me to get them to agree because it's like, well, there's something wrong with me, and I'm like, there's not. There's not. Like, your experience right now is your experience, but I think we can have some additional people to support you. So I think, one, with the limited resources and then limited time for patients to go, like, they'll be like, that's another appointment I gotta go to. And then also just the stigma, like a lot of patients just are like, I have a buddy that I talk to about this, and they aren't ready to open up to have a therapist.
I'd say that's one of the nice things with telehealth, like you're
Yes.
saying, is now, like, there's a lot of patients that are pretty far away.
Right.
Our community's jumped on board, like,
That's great. I need to do whatever y'all are doing because I just have so many patients that, they're like, I mean, they'll even say, well, I don't want to take this medicine. And I have to say, okay, if you had diabetes, would you take insulin? Like your mental health is equally important as the physical body. If you are stressed and anxious, your cortisol level is going to go up. Like that impacts your health. So I'm not the doctor to tell you to stop your meds.
Hi, good morning.
Good morning.
I'm from the policy and public health side of maternal health, and as I refamiliarize myself with Georgia's landscape, I want to ask, in your opinion, to what extent are physicians involved in the policy implementation process, and what barriers do you have or experience when coming forth to policymakers? I only ask that because I'm from Pennsylvania,
Yeah.
so Pennsylvania is not Georgia, but we like to hear from our physicians in
Yes.
Pennsylvania, so.
Well, I haven't been tasked to do anything with policy yet. But I do think I'm sorry, what'd you say? Yeah. But I do know that we have a Georgia OB-GYN society, and so I know that they are actively involved, and I know that there's physicians, I know that are, huge proponents of some of the initiatives that we have. So I think that we do have some leaders in it, but we aren't where we need to be. It feels like it's been coming at a snail's, like it's been slowly moving in the right direction. But I think on a more smaller scale, depending on the facility you're in, you can probably make a bigger impact, in terms of policies and protocols just within your facility that you can then maybe expand to our outreach or outlying hospitals.
Thank you.
Yes, whoever has their hand raised right now. Oh, no, I think it was someone in the back.
Touch on advanced maternal age and the preconception counseling. What panels, if any, would you recommend a potential couple to request to see what, if they really want to make that decision to become parents?
So,
You understand?
yeah, so I think if you have a couple that's AMA, let's just say that they are 38-year-olds. The only thing that they could probably do ahead of the game is maybe just some carrier screening in terms of genetic testing, because everything else is once they get pregnant. Anything, if they have any health issues, like if I have a patient who's 40, 41, I'm going to ask you, are you up to date with your pap smears? Are you up to date with your mammograms? If you're 45, I'm asking you, all the normal health maintenance, you still need to have that done beforehand. But if it's specifically things like genetic conditions, I would say carrier screening is probably the thing that they would need to have done. Most of our patients, so I had a slide that I had this case on here. I had a patient who was 40 years old, and she underwent IVF with her own eggs. So we know that sometimes as we get older, as we get older, our eggs are not as viable. So sometimes patients will do donor oocytes. Well, this patient elected to use her own eggs, and she had IVF with PGT, which is pre-genetic testing. So that's basically like you have the embryo, before they implant it, they take a few cells, and they determine if it's a genetically normal embryo. They don't see any big, chromosome deletions or anything. That PGT was normal. She comes in to see me for an ultrasound and for a consult, and I counsel her, and her scan is normal, okay? There's nothing on her ultrasound, but I offer her genetic testing because we offer everyone genetic testing. Her genetic testing came back positive for Down syndrome, okay? And she was floored because she thought she had a normal, and quote her, perfect baby. And so I had to do some digging and explain to her, like, hey, I know you had this testing, but this is not the end all be all. So that's why I have to tell patients, like, sure, you can have this carrier screening, but it's not going to tell me ultimately if you have a normal baby from a chromosome standpoint. And ultimately, this patient, she had an amnio and it had Down syndrome. And so it was pretty devastating for her because she had done all this planning and all of this. But all that to say is that you can't plan for that. Not even that's not going to be the end all be all. There's no 100% test for everything. Yes.
Question about the low-dose aspirin. I know that ACOG has made some recent recommendations, and I just wanted to kind of get your feeling that utilizing the low-dose aspirin across the board, similar to prenatal vitamins.
I do. I tell them to take it with their prenatal vitamin. That's essentially, I'm like, just take it. Now, I will say, one of the challenges that I've encountered is I have gotten feedback from patients that the pharmacist has told them not to take the medicine. And I also had a feedback from a patient who had a cardiomyopathy where the pharmacist told him not to take the medicine. And I will tell you, I'm a straight shooter and I play no games with my patients, so I did call that pharmacist. Because I'm like, you're not gonna have me having a DC to JC. No, we are gonna take care of these patients. So I tell patients, I already forewarn them, I'm like, hey, you don't need a prescription, but if you ask the pharmacist, they're gonna tell you no. But I'm the OB-GYN, I'm gonna tell you why. And here's the layout. So essentially, yes, I tell them, I say, take it whenever you're gonna remember it. If you remember it after you brush your teeth, take it then. I'm fine with that. I just want you to take it. So all of my patients are essentially on aspirin because everybody's high risk in my office. Yes.
Well, I have a couple questions, but just with that, when you were talking about kind of leaving everything, when you were talking about the birth team, dad, pharmacist, I think thinking more integrative and not just on the lead.
Mm-hmm.
To a little bit of what you were saying, but then there was kind of an isolation too. So I think I just actually talked to a clinical pharmacist and she was talking about if there could be a conversation, because they do actually help all the patients that come in.
Yeah.
But just kind of broadening that idea of they're gonna all say no, because they're probably having a conversation with them that's a little more integrated like yours, but just from the other side. So I think part of what you're saying is good. It's just be more expansive, because I think that will help, especially for the high risk.
Yeah, I think in the inpatient side is easy because they're at the hospital. The challenge we have is the pharmacies that are everywhere that I can't reach out to. And I certainly don't have a problem educating people about, what we're doing in obstetrics and why we need these things. But, it's occasionally the times where patients come back and they're like, well, I never got it because of this. And I'm like, the response is, well, I heard she was pregnant. I'm like, well, but did you stop her from getting the antibiotic that she didn't need? Like, what are we doing here? I'd rather, to your point is, I would rather, because I'm an over communicator, I would rather you call me. If there's a question about this antihypertensive that seems a bit unusual, I would rather you say, hey, let me give you a message. Is this really what you wanted? Because rather than telling the patient, no, you can't have it because it's bad, because what that then does, it creates a different situation in the patient's mind that they don't think that I know what I'm talking about and that I'm giving them something harmful, rather than calling. It's just no different than I see a patient from a doctor and I might be like, well, I probably wouldn't do that in my head. But I'll say, let me talk with your doctor so I can make sure they're on the same page and we all are doing the same thing, as opposed to me saying, well, I certainly want to give that medicine to that patient. That's the kind of approach that I think that both parties would need to have.
Hi, good morning. My name is Shira Lawrence, and I'm a childbirth educator and full spectrum doula. And one of the things that I did not hear you mention today, but I feel like it kind of bleeds over into all the things you mentioned, is that individualized care that a doula brings to the support of a high-risk mom. One of the biggest things we see here in Middle Georgia is there has become a huge distrust for the medical industry. And unfortunately, I also see where it feels like a tug of war for the patients. People like myself tend to recommend more holistic routes, and we try and give patients options that don't necessarily involve what we consider to be hyper-intervention, or sometimes a one-time fit-all, one client, one medication, or one plan fits all, like how you said, I give all of my patients aspirin. And so I wonder, what is your thoughts, or have you given consideration to the idea of welcoming doulas into even the visits that they have, so that there can be a continuum of care and that clients don't feel like they're being pulled between two worlds when they desire something more holistic?
So I would say two things. Yes, we do welcome doulas within our facility. We consider them a part of the healthcare team. If a patient told me they want to bring their doula to their prenatal visits, we would have no problem with that at all. I would say, though, our patient population, specifically mine, is a little bit unique in the fact that while some patients want minimal intervention, there's some conditions that it's hard for us to not have some sort of intervention. So I do have to be realistic with some patients and say, okay, I know you want less of this, but this is the reason why. I think, to your credit, that there's a lot of reasons why people don't trust the medical field. I mean, I hear stories all the time. People come to me and I'm appalled at things that happen in hospitals. But I think that just goes back to really just communicating with patients about what they need. So the way I frame that is I'll ask the patient, what is your birth desire? Okay, what is your desire for this pregnancy? I just leave it open-ended. I don't say plan, because plans never go the way you want. What is your birth desire? They don't. They never go the way you want. So I'll say, what is the desire that you have for this pregnancy? Is your desire to have an unmedicated labor? Tell me why. Does it make you feel more empowered? Let's talk about how we can be successful at doing that. Or if they have a list of things, I'll say, let's bring that in early so we can talk through all of this. The worst time is to come in when you're trying to have your baby and you're like, I have all these plans. And then you have someone who's rigid and who's like, okay, I don't want to do this. I'm not comfortable with that. So I think that opening the door of, yes, you have this medical problem, but you know what? You've been dreaming about what this baby delivery is going to look like. So let's maybe talk about how we can meet somewhere in the middle. I don't want to be connected. Well, we have wireless monitors. How would you feel about that? Like, how can we meet you in the middle when you have all of these medical conditions? So the short answer is, if a patient said to me, I want my doula to come to my visits, great. It'd be great to meet you ahead of time, as opposed to in the delivery room, because it gives us an opportunity to build a rapport. But also, like I said, I try to tell patients, like, what does this look like for you? It could be as simple as, do you want us to play music while you're in there? Do you want us to we can't have candles, people, but do you want us to have plug-ins, which I think are also a fire hazard? But do you want us, what does it look like for you? How can we meet you at your needs? And it's like I tell my residents, I'm like, listen, you can't make people do what you want them to do, okay? That's not what we're here to do. I'm here to meet you wherever you are, okay? Sometimes I might be meeting you in a place that I don't really feel good, and that's okay. I'm gonna tell you that, but I need to meet you where you are. So that was a long answer to saying yes, I'm fine with doulas. Yes.
Hi. I'm probably good. Thank you. Hi, my name is Tamaria. I'm a fourth-year medical student, applying to OB-GYN soon, so I'm very appreciative of your work. I'm thankful that I got to hear your perspective today, highly valued. Question is pediatrics. So I'm in love with obstetrics and gynecology. I love pediatrics as well. But I just wondered, has there been any discussion or is there any thought about partnering, especially in health deserts, OB-GYN care with pediatric offices? So, I have a 4-year-old, and that process after having a baby, I gotta get checked up, she has to get checked up. So I just wonder, moving forward, if there's an idea that if pediatricians can work with OB-GYNs in those deserts to make it easier on the family, bring your baby in, also let's get yourself checked up.
Yes, I thought about that. And I remember I was thinking, like, man, what if we had someone at the peds office, and I think the pediatricians kind of, and I'm just using this general, sometimes if they don't have the support to help with a blood pressure check on the mom, what is happening is that there are family medicine physicians who can serve both roles. And so at our facility, we have a family medicine OB fellow, which some of them, their plans are to go and practice in rural areas. And I'm gonna be the first to say, sometimes OB-GYNs they be pushing back at family medicine physicians doing OB for whatever reason. There's a lot of them, but I think highlighting hey, we have areas that we can have someone to serve where you're not going. So I think to that end, I think some of our family medicine colleagues, and I think there's been some rural tracks that allows them to go out and practice, because they can do obstetrics and they can do peds and complete care. All right, any other questions? All right, oh, we got one more?
Just one more.
Yes.
One recommendation. You spoke about remote patient monitoring and different things like that. I would ask that you consider adding your CMO or your insurance company to your care team, because many times those numbers are part of their case management programs, and they have things like remote patient monitoring that can help. So you're not getting an email from the patient, or you have, kind of scurry around and kind of blood pressure cuff and those types of things. They can certainly help facilitate that. So I would ask, especially with your high-risk members, that you consider pulling in those case managers or that CMO, chief medical officer, to help facilitate getting those numbers what they need.
Thank you. I got her on my cell phone.
And I would just say that's what I was trying to say about, I'm also a doula, 28 years retired.
So I definitely the collaborative.
Yes, yeah.
And every I've been in all doctors' appointments, so it never was a question, it was never, that's what I'm saying, just that collaborative team, including that, is the difference.
Yeah.
I'm like, I didn't have as many problems as the younger people do today, because I just made sure that we require the connection.
Yeah.
And developing that reciprocal relationship of who can give you the most information.
Yeah.
Yeah, so.
It's unfortunate. What's happened is there's been so much resistance with doula care and midwifery care, and there can be safe and good, great, excellent doula care and midwifery care. It's just I think sometimes people have encountered just turf wars, okay, about what happens to the patient. And sometimes there's been some things that have not happened appropriately, and I think all that people just keep it in their head, and there's not a time to just sit down and say, all right, we got this patient, we all want to do the right thing. How can we all agree to what we need to do? And unless you communicate and just leave the floor open for the patient, they'll never know it's even an opportunity.
9 times out of 10, that's from the clinical side.
Yeah.
Because we just come in as love, right?
Yeah, I know.
And also, to be clear, and this is for everybody, I'm sorry, but also, I mean, people got PhDs, they actually are public health people, you never know who's walking in the room. Period. Or they're advocates from training and community organizing, but around maternal health, we learn to do that collective work.
Well, along those same lines, I guess I would add before, and I know y'all probably tired of me, is advocacy, okay? And so I think one of the things that is important is for patients and their family members to advocate for them. And that's one thing I'll tell patients in the room, like, okay, you got high blood pressure, you got this going on, but if you show up to this, if you have this at home, you go to the hospital and you demand that they take care of you, right? And they'll be like, well, what does that mean? I'm like, tell them, call me. Like, you know, like I said, that if you show up, you are not to be turned around, that someone needs to do these things for you. And I'll tell the family member, don't let them just easily walk out. So I think that, to your point, it's the doulas who serve as advocates for the patients. And I think sometimes, like I said, I think that there's resistance. Right. And that's what I think sometimes is the perception. But unless you have the opportunity to meet ahead of time and kind of have these conversations and engaging them, then it's hard for people to meet at the same place and have that collaborative team approach. Dr. Callan's got a microphone. She's ready for me to go.
Dr. Reddick, thank you for
Thank
coming
you.
today. Regardless of what happened, the weather or travel, we were gonna get you here. I had to send a helicopter to Savannah to pick you up. We would have arranged that for you. Thank you so
Thank
much
you.
for being here today. Everyone, let's
Thank you,
give a
guys.
round of applause.